This is Sarah Berga, Professor and Director of the Division of REI at the University of Utah, and today's ASRM Grand Rounds webinar series is on neuroendocrine, basis of common reproductive disorders, pathophysiology, and diagnostic evaluation. And this is broken into two parts, just to give a little pause. So I'm going to launch with part one now, and here are my disclosures. At the conclusion of this presentation, participants should be able to discuss the neuroendocrine physiology and function and diagnose and manage patients with conditions and diseases due to neuroendocrine pathophysiology. And these learning objectives are taken from ABOG, and here are some of the objectives in ABOG that the fellows and other REIs are guided to learn. And so we will launch through some of these right now and focus primarily on understanding deficiencies of the hypothalamic pituitary system. So, patient MPR. You are called by the obstetrical floor nurse to see a postpartum patient who has become confused. The nurse is not a native English speaker, and the patient is. You obtain the following history from the patient and the nurse. She delivered 36 hours ago, and the infant is fine. The delivery was complicated by a postpartum hemorrhage. The patient did not have an IV in at the time because she had talked her physician into an all-natural birth plan. The patient is a good historian, but she's not feeling clear-headed. Vital signs are stable. She was transfused 2 units, and her hematocrit is 32%. Note, the output is significantly greater than the intake, and she has noticed already after 36 hours that she cannot lactate, and she has had 2 children before and has nursed those children. What do you want to know or do next? So here is an anatomical display of the pituitary gland and its vasculature. So you can see the pituitary at the base of the hypothalamus over here. And this is an enlarged view, and the pituitary is sitting within the sella turcica. And you can see that there's a vascular supply that's coming into the stalk, and vascular supply that's coming into the endocrine part of the posterior part of the pituitary here. So this is the endocrine portion, and this is the posterior portion, which makes oxytocin and vasopressin. Here are the hypothalamic neurosecretory cells. So these cell bodies exist in the hypothalamus, and they send projections into the posterior pituitary and are vulnerable to damage at the stalk level for not being able to supply the posterior pituitary. The anterior pituitary gland, shown here, is primarily under stimulation from hypothalamic neurons, which are not shown here, with the exception of prolactin, which is under suppression by dopamine. So this is just an even larger view of this plexus, and it is a low-pressure plexus, and because the pituitary enlarges at the time of pregnancy, actually there's a sort of a critical amount of blood supply needed to keep the pituitary working well, and it is subject to anoxic insult when there is like a hemorrhage, as the patient had. So the question is, does the patient have any kind of pituitary deficiency that's presenting? And again, just to reiterate, vasopressin and oxytocin are produced in these cell bodies in the hypothalamus. The projections come through the pituitary stalk to the posterior pituitary, and the patient's complaint, or the nurse's complaint about the patient, is there's much greater output than intake. And when you talk to the patient, you find out that she's thirsty, she can't drink enough, and when you look at the urine, you find that it's dilute. So again, just in thinking about what else could be going on, one has to understand that the stalk actually contains neurons that project both to the anterior pituitary and to the posterior pituitary. So in considering this situation, one would formulate the concept that the patient might have a vasopressin deficiency, but one would need to also be mindful of the fact that there could be other types of deficiency. So some of these are more critical than others. This is growth hormone, this is prolactin, this is TSH, this is ACTH, and this is LH and FSH or gonadotropes. And in fact, in the anterior pituitary, there are essentially zip codes, with gonadotropes being represented along this narrow strip, thyroid tropes here and over to the side. Corticotropes actually have a very small zip code, and somatotropes and lactotropes are here, and then over here you have melanotropes. So in this anterior pituitary, there's a great deal of complexity that isn't typically portrayed or well appreciated. And again, these are some of the releasing areas in the hypothalamus that project to the anterior pituitary as well as to the posterior pituitary. And I think this is a particularly excellent illustration of these relationships. So your differential diagnosis at this point is Sheehan syndrome. The patient actually has a postpartum hemorrhage. You can often see hypotension and sometimes disseminated intravascular coagulation, which this patient did not have, but she did have hypotension. And when there's insufficient blood flow for an enlarged pituitary during pregnancy, one has to suspect stalk damage or direct damage to the adenohypophysis, the anterior pituitary, or the neurohypophysis, the posterior pituitary, and of course you could always have a mix. So the lessons of this particular patient are that she presented with diabetes insipidus. The pituitary gland roughly triples in size during pregnancy, and the blood supply may be less than sufficient even during pregnancy. Likely, the postpartum hemorrhage further compromised the oxygenation of the stalk and the pituitary, and the failure to lactate could well be due to more than just posterior pituitary compromise from oxytocin damage. And one needs to be mindful that the hypothalamic pituitary adrenal axis and or hypothalamic pituitary thyroidal axis must be carefully evaluated and replaced immediately if found to be deficient. Sometimes recovery is possible, but the time course will be difficult to predict. And as we just reviewed, not all pituitary cells are equally necessary nor equally vulnerable. The next is to review some of the circumventricular organs, the neuroregulation of the menstrual cycle, and interactions that occur in that domain. So we're going to start here. This is a diagram of the brain influencing GnRH, leading to alterations in LH and FSH, which drive then gonadal function. And we have long-term the part of the brain where GnRH is made and signals released, the GnRH pulse generator, due to the fact that it was initially discovered as electrical pulses that corresponded with LH pulses in the circulation in a primate model. So this is an idealized menstrual cycle, not anyone's real menstrual cycle, but again, you see these relationships shown here anatomically with the hypothalamus, pituitary releasing LH and FSH to drive the ovary, and the ovary then regulating through feedback loop both the pituitary and the hypothalamus. And when all works well, in the follicular phase, we have a pulse frequency that approximates 90 minutes, one pulse every 90 minutes. And then under the influences of estradiol and progesterone, we see a slowing and enlarging of the pulses. So the pulse amplitude goes up and the pulse frequency goes down. And this is what you see in the luteal phase. So the follicular phase is what we call the first half of the menstrual cycle when speaking about what the follicle is doing. And the luteal phase, of course, is in reference to the corpus luteum shown here, which it starts to form at the time of ovulation. So normally the endometrium is the passive recipient of signals and responds in kind by developing first proliferative endometrium and then secretory endometrium. And so when we're talking about the ovary, we use the word follicular and luteal, but when we are talking about the endometrium, we refer to its stages as proliferative and secretory. So you can see all of these relationships diagrammed here, and it's particularly important to understand that the proximate cause, the initiation of the menstrual cycle, requires appropriate GnRH input for roughly 12 to 14 days for folliculogenesis to occur to the point of ovulation. And what's important to remember about these relationships is that when pulse frequency is roughly once every 90 minutes and estradiol levels are low, as diagrammed here, then FSH release will predominate over LH release, shown here. But as estradiol rises, it will suppress at the pituitary level FSH and will allow more LH to be released because the pulse frequency will start to speed up ever so slightly. And then you have the positive feedback of the LH surge. And that is in part triggered by not only a very exponential rise in estradiol shown here, but it also requires for a full LH surge a progesterone rise such that progesterone exceeds 1 nanogram per ml. So all of these relationships are very intricate, and there's a lot of crosstalk that's going on. And to get a completely what we call normal menstrual cycle with roughly a 12 to 15 day luteal phase, we really must have a exact pattern of estradiol and progesterone. And I think it's sometimes poorly appreciated that progesterone plays a role in allowing for a full LH surge. So understanding these relationships at the hypothalamic level and above is also important for understanding how GnRH release gets regulated. And so these are some of the organs around the third ventricle, and these the periventricular nucleus is shown here. The arcuate nucleus is where most of the hypothalamic neurons that secrete GnRH will live with their cell bodies. You have over off to the side, just as a landmark, the optic nerve, and then you can see some of these other areas such as the dorsomedial nucleus and the lateral hypothalamus nucleus here, and the ventromedial nucleus here. And these areas regulate appetite and water and stress, and have lots of interesting relationships with one another, and we are going to delve into some of those in just 1 minute. This is a stylized diagram of some of the influences on GnRH neurons. So they're shown inhibitory inputs and excitatory inputs, and some of those entities are shown here below. So there's an enormous amount of regulation that goes on, and we have spent roughly the last 30 years trying to work this out, and it's been quite a journey. So this is a beautiful illustration by Gloria Hoffman of GnRH touching GnRH neurons. And the black neurons that are wrapped around these brown GnRH neurons here are actually MPY neurons. And what's happening is GnRH neurons are actually strangers initially to the hypothalamus. They are olfactory neurons that grow in to the hypothalamus. And so they have to take a trip. And if they don't make the trip, there's an insufficient number of them. And what allows GnRH neurons to leave the olfactory plateau and migrate into the hypothalamus is still an area of active research. But there are lots of factors that have been identified and lots of genetic causes in which GnRH neurons don't actually make it to the hypothalamus and or don't set up the kind of connections that are needed. These connections are important because you need actually synchrony of pulsatility among the GnRH neurons for there actually to be GnRH pulses that drive the pituitary. So as shown here, There are 3 GnRH neurons talking to one another. And when they have an accumulation of activity, such as they pulse at the same time, then you get a sufficiently large GnRH pulse into the portal circulation to actually drive an LH pulse and FSH release. So this is very important to understand, because without the hypothalamus functioning at 1 pulse every 90 minutes in women and every hour in men, you really will have insufficient pituitary stimulation, and that leads, of course, in turn to insufficient gonadal stimulation. So we have focused for many years on understanding what might regulate GnRH, and we call the collection of factors that suppress or inhibit GnRH pulsatility stress. And some of the stressors have been identified and include energy balance, which is thought to sensitize GnRH neurons to other kinds of suppressive signals. And we have thought also to understand if some people's GnRH pulse generator is more sensitive than others. And that's been a fairly fruitful area of investigation and is clinically relevant. So I'm going to review some of this. So why would we care? First, in our presentation would be infertility. But we also understand that stressors can actually lead to preterm labor and may play a role in the fetal origins of adult disease and obesity and cardiovascular disease. And so the question is, if stressors are thought to inhibit or suppress GnRH and lead to either anovulation, amenorrhea, or just unexplained infertility, 1, how would we identify that? And 2, what would we do about it? So we have focused for many years on understanding behavioral contributors to stress, and in particular seeking to understand cognitive factors that actually lead to stress, and then with the goal of helping individuals to identify those particular cognitions and learn to modify them. So in terms of understanding the hypothalamic pituitary gonadal axis, it's important to understand that it's just one of the manifestations of stress. So what is stress? People have often sort of said, well, it's impossible to define, but actually we can make models in the lab for understanding stress, and stressors roughly break into unrelenting, unpredictable, and unresolvable. And some of these are referring to things that are external, but we also know that an individual's response to the external environment actually can either be excessive or actually perhaps not sufficient, and also carry neuroendocrine consequences. So the neurobehavioral responses often manifest as dysregulation of the limbic hypothalamic pituitary adrenal axis, a chronic activation of the sympathetic nervous system, and either adaptive or maladaptive behaviors that ensue. But under a condition of chronic stress, not only do you get reproductive compromise, you often get disordered eating, reward deficits, affective disorders, and of course, bone loss, cardiovascular disease, including stroke, and immune dysfunction. And we're not going to be able to focus on all of that today, as that's a pretty long topic, but just to understand how this might play out, we can break the stressors into 2 categories. These are not actually real categories in the sense that cortisol, because it is both a metabolic hormone as well as an indicator of psychogenic stress, plays 2 roles always. So you can't say cortisol is just a marker of psychogenic stress, and you can't say that it's just a metabolic hormone. But if you have high cortisol, it often indicates both that there is psychosocial stress, and we can know for certain that there will be metabolic consequences. So in understanding stress sensitivity, then, we really want to understand what makes the limbic hypothalamic pituitary adrenal axis of some individuals more likely to chronically oversecrete cortisol than others. And some of those cognitive features are shown below. So if you feel like you have no control, that actually is often called in an animal model social subordination. If you feel like perfectionism is required or that it is necessary, these are attitudes that often or conditions that often lead to stress sensitivity. And in particular, when coupled with a high need for social approval, which I often refer to as an external locus of control or conditional love, it may lead to a pattern of hyperreactivity to the environment. On the other hand, if the environment itself is so stressful that it cannot be controlled in some relatively predictable manner, then that individual will experience a lack of control regardless of cognitions. So most of life is a blend of things that you can't control and things you might be able to control. And when you're thinking about individuals that have infertility, really it's important to focus on the things that are controllable, that are attitudes that the individual possesses. So there aren't always things that one can do about the external environment other than recognize what would be a sufficient adaptive response. So what happens when you have chronic activation of the CRH ACTH drive in women is shown here. So first of all, it presents primarily as an elevation of circulating cortisol, and we have shown also that that is associated with an increase in CSF cortisol, and I'll review that in just 1 minute. But when you have chronic activation, and it's usually called limbic hypothalamic pituitary adrenal axis because it really is your limbic lobe that in part determines the importance of any stressor. So for instance, if you want to go to medical school and you don't make good grades, then you, if you're halfway aware, will know that that's not going to work. And so you have the understanding that you have to make good grades in order to achieve an objective that you want. If, on the other hand, you're taking the very same courses, but you do not have that expectation of going to medical school, the same course might be much less stressful to an individual who doesn't feel like it's an absolute requirement for their career. And so it's the same class, if you will, but not always the same response to that class that can drive individuals to be more sensitive. So one of the secondary consequences of a chronically elevated hypothalamic pituitary adrenal axis actually is in the suppression of the TRH-TSH system, which results in lower T3 and T4. This is really important to understand because these two are linked in an obligatory fashion. In other words, if this happens, if you do have actually increased cortisol via activation of the limbic hypothalamic pituitary adrenal axis, you will have suppression of the thyroidal axis. And it's important to understand how that presents because screening with TSH alone will not allow you to identify this. And in infertility, we know that thyroxine plays a very critical role in embryogenesis and pregnancy. But often what will happen then is a partial or complete suppression of GnRH drive. And that can present, is shown here. These are LH pulses. So these pulse patterns were derived by obtaining blood every 15 minutes for 24 hours and then measuring LH in duplicate and then plotting the values. So this is a eumenoric woman with a progesterone that was in excess of 10 nanograms per ml in her luteal phase. And this is a follicular phase pattern, roughly day 3 through 5 of LH. And you can see the classic nocturnal slowing that occurs. And then this pattern here actually is what we often term regressions to pre-puberty. So instead of there being nocturnal slowing of LH pulses, actually see an increase relative to the daytime. So you have, instead of having roughly 15 to 16 pulses per day, you have 4 pulses. So this is important to understand because it demonstrates very clearly that the hypothalamic pituitary communication is intact. So unlike Sheehan syndrome, where this might be broken because of either anterior pituitary damage or stalk damage. Here, the connection is just fine. So one infers then that the GnRH message, the GnRH pulse frequency, is dramatically slowed relative to normal, as both of these individuals had low estradiol and low progesterone at the time that these LH patterns were derived. So it's important just to look briefly then at the thyroidal manifestations. And here you see that eumenoric women have TSH levels in this particular sample. And this is normal weight women, both FHA and eumenoric women, who were in the age range 20 to 35. And the FHA women, functional hypothalamic amenorrhea women, actually reported at least 6 months of amenorrhea, and all had previously had normal menstrual cycles somewhere in adolescence. So here you see that TSH levels were identical, and a single sample of TSH is unlikely to allow you to discriminate between these two groups. So in order to look at this group and understand what's going on, one has to measure either T4 or T3 levels. Here we see T3. And the T3 level is roughly more than 50% less than in the eumenoric women. And this tells us something very important, because normally if TSH needed to be higher, then TSH would go up. Normally when T3 is lower, TSH would go up to drive up T3 and T4, but that's not what you see happening here. So at some level, the body has made a hypothalamic decision, if you will, to be in power state, because this individual have a lower basal metabolic rate than this individual. And this is what we interpret as an attempt to conserve energy. So the body has been placed in power state mode, perhaps to deal with stressors, and we believe that this is, and there's lots of evidence to show that this is actually a consequence of chronically elevated cortisol and chronic stress. So this is sometimes called non-thyroidal illness or sticky thyroid syndrome, and this is actually a very old diagram from 1986, but it's a beautiful illustration of what happens when you have sort of what we call hypothalamic hypothyroidism. So if this is, for instance, a burn patient, T3 goes down to conserve energy. T4 is the next to actually reduce, and then free T4 is almost always normal. And this represents the body's maintenance of homeostasis even under extreme conditions. So if one wants to know what energy state an individual is in, it's actually better to follow T3 than to follow either T4 or free T4. But what you can see is when the T3 drops in a stress-related environment, whether it's chronic illness or chronic other sorts of stress, the TSH stays low in order to allow this to happen. And some of the T4 is actually made into reverse T3, again, to protect the body from excess metabolic strain and to slow metabolism and allow it to cope with the stressor at hand. So how this looks in women who have hypothalamic amenorrhea that's functional, i.e. not due to some organic cause, is shown here in terms of cortisol in the circulation and cortisol in the CSF. And we did this particular study because we wanted to make sure we understood that the brain was actually getting the cortisol signal that we saw in the circulation. So the circulation cortisol level is roughly 20% increase over that of eumenoric women. But of note, there's a more dramatic increase in the CSF cortisol. Interestingly enough, as like with thyroid, instead of there being an elevation or a decrease in CRH in one relative to the other, they're actually the same. So you have sort of hypothalamic hypercortisolism because normally if you have an increase in cortisol, you expect CRH to go down, and that's not what you see. And why women with chronic stress, including those with functional hypothalamic amenorrhea, do not look cushienoid as shown here And that's because CBG will rise to try to, like with free T4, control the free cortisol fraction. So there will be a bigger increase in the total cortisol than the free cortisol. And again, that's actually to protect the body. But inside the brain, there is really a large message because this is free cortisol. The brain doesn't actually have these binding proteins. And so you have a really rather profound signal to the brain that the individual's in a state of chronic stress. And these all travel together. This is a beautiful study done by Ann Laux some time ago, in which she gave eumenoric women graded decreases in energy, and watched what happened to LH pulse number, cortisol, and glucose. And it's important to understand that when you have a deficiency of energy, you actually do get a reduction in circulating glucose. And so these all travel together such that the larger the energy deficit, the slower the LH pulsatility, the larger the activation of the hypothalamic pituitary adrenal axis, and the more the individual have glucopenia. So imagine you take a person like this and give them a next stressor, and how would they respond when they're already compromised is probably with an even larger response than the person who's already in a pretty good shape metabolically, as shown here. So we did something like this with monkeys, and so the chronic stressors that we made for them to experience were a small reduction in calories and an increase in exercise. So the monkeys were asked to run 2 to 3 miles a day on a treadmill, which they seemed to enjoy, and we gave them a 20% calorie restriction. The other stressor that they experienced was moving. So the monkeys were singly caged, and they are in a room with neighbors, and they get into a relationship with neighbors. And one thing that's very stressful for monkeys is if we move them frequently. And that would probably be the same for humans. If you actually can't control your environment, you can't predict your environment, it's going to be pretty stressful. Even if nothing really bad is happening to you. And so if we had you, for instance, go to a new office every day, or go to a new house every day, or a new hotel room every day, that's sort of analogous to what we had the monkeys experience. So when we did that, if we just gave the diet plus exercise paradigm, about 10% of the monkeys were transiently anovulatory. And when we just gave the psychogenic stressor of move, same. But when we combined these two stressors, actually had a profound synergism between the two. And we actually think that's what's happening with humans, that they don't report one large stress, or they don't report one, single dietary insufficiency or exercise bout, but they have a chronic mix of over-exercise or over-energy expenditure, a relative deficiency of caloric intake, and then they have the instability that might be called lack of control. And when you put all of that together for humans and for monkeys, that actually compromises GnRH release by activating the HPA. So we did something similar with humans, just to prove the point. So these are women, either eumenoric women as before, and in our paradigm, eumenoric means that they had a luteal phase progesterone of greater than 10 nanogram per ml. And the functional hypothalamic amenorrhea designation means that they were normal body weight, did not have an eating disorder, and did not have a DSM diagnosable disorder. And so they were comparable in BMI, and so they did not look like they were energy deficient, but they were amenorrheic. And then we gave them an exercise challenge, and the exercise challenge was to ride on an exercycle to 70% of VO2 max. So the patients or the subjects that were eumenoric had a release of glucose to meet the energy demands. Of note, the patients that were amenorrheic actually had a decrement in glucose. And this led to a greater rise in cortisol during the exercise bout in the amenorrheic women than in the eumenorrheic women. And that actually represents part of the stress signal. So when you decrease glucose, as we showed before, then that actually makes the brain unhappy, and it will try to mobilize glucose by sending an extra large cortisol signal to the liver. But if the liver is chronically depleted by actually seeing the cortisol signal all the time, it may not actually be able to generate enough glucose to deal with the next energy requirement, in this case, this exercise challenge. So this is actually shown beautifully here, and there's a couple key points I'd like to emphasize. So this is eumenorrheic women who are during that exercise challenge, and here are the women with functional hypothalamic amenorrhea. And what you can see here is that we tell them they're sitting on the exercycle, bicycle, and we tell them in 10 minutes the exercise bout will begin. The women who are amenorrheic already start to experience a decline in glucose, probably because of psychogenic activation. And this has been demonstrated in other sorts of paradigms as well. And then when the exercise challenge begins, and it's only 20 minutes long, they continue to drop their glucose. And it does recover rather promptly, which is good. But you can see that if they exercise for longer than 20 minutes, it's hard to know how low the glucose level would go. And that would probably, as we showed before, activate the hypothalamic pituitary adrenal axis to a greater degree, lead to greater suppression of the thyroidal axis and greater suppression of the hypothalamic pituitary gonadal axis. So we've been talking about this in women, but we know that the same can occur in men. So what do we call this? We call this allostasis. And what that means is the hypothalamus knows that the estradiol level is low, but makes an executive decision that it's going to conserve energy by not increasing gonadotropins and not trying to get the ovaries to ovulate. And this is why we think these individuals, despite having a reduced C2, do not present with hot flashes. It's because the hypothalamus actually is insensitive to the estradiol level. And then we see, or hypersensitive to the estradiol level would be another way to think about it. The hypothalamic pituitary adrenal axis is activated, and there's feedback inhibition to cortisol. So although cortisol is elevated, CRH does not go down, and this also leads to altered metabolism, particularly if it's chronically experienced. And then the same for the hypothalamus and the thyroid. So we have hypothalamic hypothyroidism, sometimes called sticky thyroid syndrome. And as we showed, decrease in T3 and T4 without a compensatory rise in TSH also leads to energy conservation or power save. And you wouldn't really want to give exogenous T4 in this setting because it really wouldn't lead to the right circumstances. In other words, it just might suppress TSH. And the body has made an executive decision to be in power save, and so the T4 might actually just get turned into reverse T3 rather than the active hormone T3. And we know that the fetal brain has an absolute requirement for T3 and T4, so we have always worried and continue to worry that this kind of hypothyroidism may actually lead to poor embryogenesis and poor fetal development. I haven't really talked much about this yet, but stress alters feedback sensitivity also to appetite signals. So normally if you give someone appetite signal ghrelin, they'll eat more. But people who are chronically stressed actually don't, and or their appetite for food changes in the sense that they prefer now high-fat, high-sugar fuels, and we sometimes call this emotional eating. So it can either lead to calorie restriction and not being able to respond to appetite signals that are, orexigenic, and it favors what we call anorexigenic signaling, and then, or it can lead to emotional eating and overeating, and it can lead to weight gain. And again, this is actually that same phenomena shown in men. This is testosterone, cortisol, LH, and FSH in men undergoing a war drill. And then at the end of the war drill, they are basically in a state of hypothalamic hypogonadism. And then part 2 of the study shows that they, in fact, do recover when cortisol comes down. So it's that same relationship. And then this is actually postmenopausal women. So they don't have any estradiol already, and they're in the ICU for a reversible cause. So when they first present, they survive whatever the cause is. They have very high cortisol levels, and by day 5, they're starting to recover, so cortisol levels go down. But what's interesting about this study is that on day 1, FSH is already reduced, even though there's no ovaries around that are functioning to make estradiol, and that decrease in FSH continues even as cortisol has started to come down. So there's kind of a delay, an echo, if you will, in the stress signal and its impact on the rest of the neuroendocrine axis. And we think that this presents an unexplained infertility as well. These are women who are also normal body weight, who have no other cause of having menstrual cycle disturbances and report regular menstrual cycles. But you can see in this particular person, we've plotted daily LH, FSH, estradiol, and progesterone, that they have an LH surge at roughly 23 days and about a 5-day luteal phase. So that would be insufficient for conception, even if the egg got fertilized, because by the time the egg was trying to implant, this individual would be menstruating. And we know that this is not from impending premature ovarian failure, because actually what you see are LH and FSH levels kind of wobbling, probably because there's intermittent stressors. And here below is a person who has what's called anovulatory cycling, so they have more or less a rise in estradiol, no rise in progesterone, and when estradiol crashes, they have a period, but their gonadotropin levels are low. So these may well be other manifestations of stress on the neuroendocrine axis of the HPO. So we like to think of this as amenorrhea being easily recognized, and all these others as being less easily recognized, sort of an iceberg below the water. And as I alluded to earlier, there's been tremendous investigation for what regulates GnRH. And now there's a whole neuronal network that's shown here that integrates the signals that we've just been talking about. So this is metabolic signals, and then these are gonadal signals. And they play upon this fascinating group of neurons that are cross-talking to one another, shown here. So this is GABA. This is POMC. So this is pre-opiomelanocortin and CART. This is MPY, which we showed earlier, wrapping around GnRH neurons. And GnRH neurons here are just shown for purposes of clarity on the other side. But the proximate signal to the GnRH neurons at the level of the portal system is actually shown here, and these are what are called candy neurons. And they operate by KIS1 receptors. And you can also see that there are insulin receptors here as well. Leptin receptors are shown over here. And so this highly complicated group of neurons have a lot of crosstalk with one another to essentially then regulate the stimulatory signaling to the GnRH appositions at the level of the median eminence. And so if K and DY is activated, if the candy neurons are activated, they're going to activate the KIS receptors, which are going to activate GnRH. So we think stress plays on this as well, and it can lead to inhibition of the candy neurons, and therefore inhibition of GnRH release. So stress sensitivity in monkeys, we talked about earlier, and there are a lot of neurotransmitter changes that actually seem to reflect stress sensitivity, and we think humans may have a similar kind of scenario in which they have actually CNS sensitivity to stress that leads to neuroendocrine hyperreactivity in terms of cortisol and all of that consequences that follow. And this is just another demonstration. I won't go through all the details because it's quite is quite involved. But basically, what you see is that there are leptin-responsive GABAergic neurons that regulate fertility through kisspeptin, and that's just to reinforce that diagram that was shown previously. And so we do believe that CRH is really the actor here, because when we reverse CRH with a CRH receptor antagonist, actually we reverse some of the findings. And this is just looking at GABAergic binding in the prefrontal cortex of monkeys. And there are two kinds of monkeys, those that are sort of the dominant monkeys and those that are the subordinate monkeys. And those are shown here. So the dominant monkeys are in the white and the subordinated monkeys in the black. And monkeys who are chronically stressed by subordination have an increase in GABA in the prefrontal cortex that's been reversed by giving the CRH antagonist. So we believe that the monkeys that are subordinated actually have altered eating patterns, and whether they undereat or overeat, in fact, depends in part on the food that's available to them, both amount and type. And so the same is likely true for humans. With chronic stress, you may overeat, particularly if it's high-fat, high-sugar food, or you may undereat, particularly if you actually don't have sufficient food around to eat. And so we can see different kinds of metabolic syndrome resulting from these patterns and accelerated aging. So it's not a benign state, and that is part of the reason that we would like to reverse it. And reversal actually is a kind of an interesting concept because it means that the individual, whether they're a monkey or a human, actually enjoys a newfound way of controlling their environment. So, and this is just to reinforce that the monkey model is relevant. This is a dominant monkeys, and their menstrual cycles are about 88% normal. And subordinated monkeys actually have a compromise in menstrual cycle function and also display, as we just showed before, anovulation and luteal insufficiency. That's pretty interesting. And those same monkeys don't dextrose for cortisol. So the more subordinated the monkey, the less likely they are to respond to dexamethasone suppression, and the lower their estradiol levels, and the lower their progesterone levels, and the lower their bone density. So this seems to be a very conserved pattern of response to chronic stress, both in humans and in monkeys. And this is just to demonstrate the emotional eating paradigm. So these are dominant monkeys fed vegetarian chow in the blue. And subordinated monkeys will often weigh less in that circumstance because they don't have the same access to the food because the monkeys who are dominant often guard it. And this is in a group setting. So there's a food box and the monkeys have to compete for the food. And when the food is actually high sugar, high fat food, the subordinated monkeys actually try to binge and overeat. The dominant monkeys, who can more or less eat when they want, don't seem to be as motivated to overeat. And then when you give them a choice, that doesn't actually make the situation any better. And the subordinated monkeys actually will still try to overeat. And then when you take away the high sugar, high fat food, interestingly, the subordinated monkeys seem to have learned to overeat. And so we think this may have important implications for understanding stress-induced obesity, which is in fact another form of that also leads to reproductive compromise, another form of reproductive compromise, or another cause of reproductive compromise. So what have I just said? All monkeys like high-fat, high-sugar diets, like humans. Cortisol levels were higher in monkeys who were separated from the troop when they actually had high fat. So high-fat diets don't address stress. They might make it worse. And higher cortisol after dex suppression predicted in these monkeys which of them would like to eat the high-fat, high-sugar diet. So if this sounds somewhat similar to humans, I think it's meant to. And it's sort of understanding why obesity and infertility might travel together as well. And the important point is that obesity per se isn't always associated with PCOS. There can be stress-induced obesity that actually leads to hypothalamic hypogonadism akin to functional hypothalamic amenorrhea. So when you see someone who's overweight, it's not fair to assume that they have PCOS or just plain obesity. And it's really important to understand that obesity might be, in fact, a marker for chronic stress. So what can we do about that? Well, we don't really have a CRH antagonist to give to humans, but if we did, it might ameliorate some of this. So this is just looking at another kind of CRH antagonist and looking at their food choices. And CDD stands for high-fat, high-sugar diets or calorically dense diets. And monkeys that want to eat the high-fat diet don't want to eat the high-fat diet when they're subordinated if they have CRH antagonists on board. So again, the dominant monkeys are not that motivated to overeat. The subordinated monkeys are. And when they have CRH antagonists in their blood to reverse the CRH signal, they actually start to look more like normal eaters. And we see these same sorts of relationships in humans. Women who have anorexia nervosa, who in fact have strong cognitions about eating, are actually insensitive to the appetite signal ghrelin. And when we give ghrelin to monkeys, it normally will slow LH pulses. It's part of the signaling system that says to the kisspeptin neurons, don't fire. But when CRH is reversed by astressin, the one that we talked about previously, the slowing of LH pulses by ghrelin goes away. So these are just other ways of reinforcing that signaling system that I was talking about earlier, in which you see activation of the limbic hypothalamic pituitary adrenal axis leading to high cortisol, playing up on GABA, and leading to a host of manifestations. And if the stressor is misaligned cognition, that's one set of stressors. If it's energy balance, that's another set of stressors. But typically, they all lead to the same impact, i.e. an elevated cortisol. And understanding how to reverse in humans actually is to understand how to actually get the cortisol level to come down. And that typically involves addressing cognition. And it's our understanding that by addressing the cognition, just like we did with the CRH antagonists in the monkeys, we may actually alter exercise and appetite patterns. So, which one of these fertility statuettes is most likely to have stress-induced anovulation? I would say that based on what we just talked about, either one of these could have it, and that the phenotype strictly doesn't tell you what the cause of anovulation would be. And so you do need sufficient energy to drive reproduction, to allow for reproduction, but sometimes oversupply of energy carries its own consequences and or is a manifestation of stress and can be due to hypothalamic hypogonadism rather than a PCOS-like picture. And the other point to reinforce is that functional hypothalamic amenorrhea or anovulation is more than just infertility due to anovulation. It always carries neuroendocrine concomitants, and the ones that we've talked about most today are the thyroidal axis and the cortisol axis. And why pregnancy and fertility are linked is shown here. It takes a huge amount of energy actually to be pregnant. So 4% increase in basal metabolic rate just in the first trimester alone, 24% in the third trimester, and those calories have to be there. And if they're not there, then the pregnancy doesn't go as well. We also know that it takes a lot of energy to raise humans. And these are fun facts, but typically it's about 13 million calories to raise a human from birth to maturity. So these calories have to be either obtained from the environment or supplied in some way. And that we think that's one of the reasons that women are so sensitive to energy supply. And so when you see infertility patients, your mind should go to the concept of, are they overeating? Are they undereating? And if so, in either category, what's the cause? And, some of the cause in some environments, as shown here, is there isn't anything to eat. But what we've been talking about is oversupply of nutrition as well, and that's a more modern problem. We think that the nutrition transition, as it's referred to, is the tendency for the world to be oversupplied with poor quality calories, so the high-fat, high-sugar diet. And we do think that one of the drivers for overeating is food insecurity. We've been talking a little bit about that in these monkey models. But now what we see is that people who were once challenged by low-calorie environments now live in high-calorie environments, and they start to look a little bit more like these fertility statuettes from long ago. Now, it must have been quite an achievement in a low-fuel environment such as the one shown above to be able to actually hold on to calories and obtain them in such a way. And I really like this little statuette here. This is on the wall of Persepolis in Iran, and it shows this is a chariot wheel, and this is the fertility statuette in the middle. And it sort of implies that part of the motivation for war was actually to obtain calories to supply the population, particularly to permit fertility. So we know that fertility is readily compromised by being too thin, and that fertility is relatively not compromised by being overweight. And so, if you had to choose between the two, and fertility was the desired goal, a little too much weight is better than a little too little, as long as the too much weight does not reflect chronic stress. So this is just the vicious cycle of metabolic imbalance fueling psychogenic challenge fueling metabolic imbalance, and we get disruption of the hypothalamic pituitary adrenal axis and the ovary axis and the thyroidal axis all at once. And the signaling systems that allow for us to eat are altered in terms of how they cause behaviors. And so now we have a sort of a vicious and sustained cycle whereby humans are either eating the wrong things or not eating often enough, and that's leading to infertility. And we know that we are wired to eat. This is shown here, same diagram systems, all these little appetite all these appetite signals here actually are mostly tilted in favor of eating. So to not eat is really a rather dramatic state. And many times it has been suggested that we tell people who are too thin to eat more, and to tell people who are overweight to eat less. And I hope I have demonstrated how futile that is likely to be, because if the motivating feature for either under or overeating is stress, you can't really just tell people that the stress doesn't exist. And you can't really unwind the signaling system that's playing on the hypothalamus. So that's why our focus has always been to deal with the stressors and try to figure out what to do for them. So we know that psychogenic challenge and metabolic deficit synergize. We know we want to undo the entire cascade so that we get a better pregnancy and a better, longer living individual. We know that, in particular, hypothalamic hypothyroidism is a fetal threat. And so we said, what can we do? And so we had talked about this previously, but we knew that perfectionism and high need for social approval were attitudes that make people more sensitive to external locus of control. And so what you see here are attitude survey in women with amenorrhea and eumenoreic women. And in particular, there's an elevation in this attitude survey that taps into these domains that we've just talked about. And You can also see over here, these are eating disorder inventories, and there are 8 subscales. I'm showing 2 here, but this is drive for thinness, which is an attitude, and ineffectiveness, which is an attitude. And this is binging, and this is an attitude. And these are normal weight individuals. But the stressed individuals, the ones with functional hypothalamic amenorrhea and that do have high cortisol levels, actually have food alterations as well in terms of how they want to eat, both in terms of under eating and eating too much. And they don't feel in control. That's what ineffectiveness shows. But they're not strictly depressed. This is the Hamilton D and the Beck depression inventory. So while these are a little bit higher, they do not meet criteria for depression. So this is our understanding of what's driving functional hypothalamic amenorrhea and its cousins, presentations, and ovulatory cycling and luteal insufficiency. So one is unrealistic expectations of self and others. Another is perfectionism and high need for social approval, which pretty much comes with the field of medicine. Poor problem solving and coping skills, which we hope to restore. And what we didn't find and thought we might find was no increase in negative life events. So we didn't study individuals who were subjected to really poor environmental circumstances like war or other sorts of really, horrendous societal problems. But instead just studied individuals who actually seemed to have a reasonable life trajectory, but didn't have a psychiatric disorder and didn't have a bona fide eating disorder, but were nonetheless amenorrheic. And we addressed their attitudes and their behaviors, but in a somewhat counterintuitive way, because we did not tell them to eat more if they were underweight, and we didn't tell them to exercise less. We simply focused on attitudes and best ways to deal with specific and common stressors. And women who were randomized to the intervention, which we called cognitive behavior therapy for FHA or stress-induced anovulation, actually had a return to menstrual cyclicity about 72% of the time, whereas those randomized to no intervention, just phone calls. So these were 16 sessions, either 16 sessions of the active intervention or 16 phone calls, as in here, and they stayed largely amenorrheic. So this is a small pilot study that has yet to be replicated, but we think it sort of is a demonstration of the principle. And just to amplify the demonstration a little, this is a woman randomized to CBT. These are menses, and here is estradiol and progesterone levels. So it took a while to recover completely ovulatory cycles. So first you get menses and probably estrogen-only cycles, and then you start to see a little rise in progesterone, and then later in the recovery period you start to see fully ovulatory cycles. And then this is an individual randomized to observation, and estradiol and progesterone levels stay flat. And the individuals who recovered actually had a decrease in cortisol, and I'm going to amplify on that now, whereas those who remained unrecovered did not. So this is the reduction in cortisol by intent to treat. So not the recovered versus the non-recovered group, but this is just the group randomized to CBT. And all the individuals completed the CBT. And the decrease in cortisol is shown here. And those who did not get randomized to CBT did not have a change. And again, the change in cortisol, the drop in cortisol, is shown here. So this is 2 24-hour patterns in the same individual, one pre-CBT and one post-CBT. And you can see that most of the recoveries actually occurred at night when the individual was sleeping. And that's shown more dramatically here. So daytime levels of cortisol in amenorrheic women due to stress actually stay pretty much the same. And people kind of go through their day looking normal in terms of cortisol. But at night is when the demons come out, And individuals are sort of solving the day's problems or worrying about the next day's problems, and they often don't report insomnia, but they probably aren't sleeping in a high-quality way. We don't have sleep EEG data to go with this, but what we surmised just based on conversations was that the individuals were sleeping better and were worrying less at night, and that was associated with a drop in cortisol. And some of the other parameters that we followed, so we looked at weight. So to recover from stress-induced anovulation, if you were normal weight, didn't mean you needed to gain weight, and there was no change in weight. Leptin levels, however, despite no change in weight, went up in the recovered group. And this is not the recovered group of the intention to treat group of CBT, but I would think this is driven primarily by those who did recover. So leptin levels were about the same in these groups, but you can see this as a change here. And TSH in the group that was recovered or recovering actually went up dramatically to try to drive up T3, but it takes a while for T3 to respond. So we think this is a diagnosis of exclusion. There's a spectrum of menstrual cycle compromise, concomitant hypothalamic hypothyroidism, and hypercortisolism, and synergism between energetic imbalance and psychogenic challenges. And the reason we like CBT rather than clomiphene or letrozole is it will lower the cortisol, hopefully allow the hypothalamus to function in a better way, and it restores autonomy and sense of social control, which has got to be better for the individual across time and better for a pregnancy if there is one. And one of the sort of unappreciated positives of CBT is that the tendency for the effect size to accrue indefinitely. So once you teach people how to think about life in a more stress resilient way, the better they get at it. And we hope that by teaching CBT, we can impact and ameliorate some of the poor socioeconomic circumstances, some of the social determinants of health, and hopefully improve not only maternal health, but child health through this mechanism.